Hello, everyone. Thank you for being here on a Sunday afternoon. This is the last panel event taking place this weekend in this very first edition of the Healthy Skepticism Film Festival. The festival has been a really great success so far. We've had some really interesting discussions in our different panels. And if you've missed them, don't fear, because they're all being recorded and you can watch them on Facebook already, but you'll surely be able to watch them on our website soon. So today our panel is about the new documentary made by Rita Conry called the UTI Documentary. This is a short doc, which if you haven't, of women sharing their and being failed by primary is Rita Conry, the filmmaker, Agnes Arnold-Forster, who's a historian of healthcare at the London School of Hygiene and Tropical Medicine. And she also co-runs the Healthy Skepticism Project as a whole with Kate Gainty. Agnes Arnold-Forster was also the brains behind the UTI documentary. Also, Joanne McKinley, who is one of the fabulous women featured in the film. There are many, you should go watch it. So today we are going to discuss UTIs as a whole and also the making of the film. So we're going to be open to questions from the public, but to begin, I have a few questions. So I'd like to hear from Agnes, Rita, about how the idea came to fruition to make this documentary. I'd like to know what was...
Carmen, you're slightly breaking up, but I have the question that you're going to ask us right in front of me, so I can just finish up and then pass over to Rita to answer, which is which was, how did the idea come to fruition, and what was the moment in which we thought we needed to make a film about UTIs? And I'll let Rita kick off.
I was going to let you, because you were the one that approached me.
That's true. So I've had UTIs, recurrent UTIs, since I was 15, 16, but I also had them as a kid as well. So they've been a big part of my life for my entire adult life. And Rita and I have been friends since we were... we first met when we were 12 or 11 or something, and we have had a shared experience of UTIs, unfortunately. And so that's obviously bad, but one of the silver linings, which I think is a kind of a theme that runs through the film, and also through the kind of UTI experience more broadly, is that, you know, it's a terrible thing to have to live with, but you do manage to build these communities and these connections with people, partly because you're being failed by people who are supposed to care for you, but also because, you know, as a historian in the history of medicine and in the history of women's health, women have always done this. They've always had to find support networks that kind of sidestep or go around the like kind of orthodox medical profession or like mainstream healthcare. And so I think Rita and I had a kind of version of that where we talked about it and sort of shared experiences. And I've also been working on this project with Kate about how to think differently about healthcare, how to kind of cultivate a more a healthier skepticism about medicine, about healthcare. And it felt to me that UTIs were a great case study for this. So something that was both, you know, deeply personal, but also something that interested me intellectually and professionally. And so I thought it would be a great combo. And I also know Rita to be an amazing filmmaker. And so she was obviously the right person to make this film, which I think is evidenced by the final product. But yeah, so I just asked Rita if she'd do it, and you didn't take a huge amount of convincing.
No, I mean, last year I was diagnosed with a chronic UTI after having symptoms for 13 years and being told I had nothing wrong with me. So and then a few months later, Agnes was like, do you want to make a film about UTIs? And I was like, absolutely, yes, that's like exactly what I want to be doing with my time. So it was, yeah, it didn't take much convincing. And then that's all I've done now since you asked in December last year. And yeah, so that's really, I mean, that's how it came about. And then Agnes had already started reaching out on Twitter to meet people or find case studies and participants for an article. And so from that, we spoke to some of those people and asked if they wanted to be in the film. And so Sophie was one of those people, who one of the participants, and she yes, and then I reached out to Joanne actually, and maybe actually it was the Facebook group. I found Joanne started a Facebook group, which I'll let you talk about that, but and saw that you were the founder, and I found you on Instagram and slid into your DMs and said yeah, you have to be in the film. So luckily you're up for it.
But I think what we both found is, like, before, maybe you didn't feel this, but I definitely felt this, that before starting making the film, and Rita was really the actual person who made the film, but like before starting making the film, like I don't think I really realized that it was such a huge topic of advocacy and like activism, and that you kind of, you know, it was like a personal project, you know, for us as a pair, but also as an individual. And then you start doing it and you kind of get a sense of how huge the topic is and how like vital some of the conversations that we've been able to have and present have been. And yeah, you know, I feel like it's such a great tool for activism. I think a film, you know, it can help tell a story in an incredibly engaging way and a persuasive way, and I hope that is what it ends up being.
Yeah, exactly, like we just said earlier before we started, but yeah, it grew into something, what initially started as just like a personal project, and we realized, well, I was trying to see what else was out there, that, you know, if there were any other documentaries about UTIs, and they really are just, you know, sort of frustrating videos on YouTube which say, you know, drink some water and this is why, you know, this is how this happens, and go to your doctors if you know, get a few days of antibiotics. So it's like there wasn't anything that delved into like what it's like to go through, and then I was like, oh wow, okay, so this could be, you know, quite a good conversation starter, and hopefully reach a lot of people, and maybe change the guidelines and things like that. But yeah,
and be a critical piece as well. That's the whole point of it, right? Is it's not supposed to just like, you know, it's like women's stories, but it's not just like people's biographies. It's like designed to be a critique of the current system. Is that fair?
Yeah, definitely. And we talked about this a lot, you know, throughout, and I mentioned this yesterday. You know, people, when I said I was making the film, people would be like, oh, so you're interviewing lots of doctors and things like that, and I was like, no, it's not. And I hadn't even thought about to do that, because I was like, well, it's not really about them at all. It's about people going through this, and their voice is kind of like, that's the consensus on like how, you know, this is how we treat UTIs, and we know that's not correct, or that failed a lot of people. So it's sort of like, it doesn't, their voice doesn't need to be in this, basically. So
surplus to requirements.
But yeah,
sorry I broke up earlier. I hope you can hear me now.
Yeah,
you're back.
Okay, great. I heard what you were so yeah, that was really interesting. And yeah, I was just thinking, if doctors had been included in the film, I guess the only way really that it would have been like interesting and adding to the critique is just in them saying how often they receive this type of patient. Because yeah, like personally, I've been to many doctors regarding my UTIs, and they always say, yeah, this is very common. Yeah, we get many women coming in with these issues. and yet they don't have good solutions, or like they're not able to signpost me to some actually helpful places. So it's really crazy, actually.
Yeah.
Yeah.
But it's something we talked a bit about as well when we were making, like, going through the editing process, is like, how much info should we include? You know, how much knowledge should we assume of the audience, from the audience, about like what a UTI is, what kind of, you know, numbers are we talking about here, like what are the current treatments? But, you know, we kind of came down on it being, again, more about like, you know, women telling the stories for themselves. But I mean, I think that would have been a perfectly valid way of going about it as well.
Yeah.
Mm-hmm. So on to my next question. What changes would you like to see in how UTIs are dealt with in healthcare?
I think Joanne should answer this one.
Yeah, definitely.
Changes. So of course the guidelines need to be changed straight away, really. So people are just not given long enough antibiotics for an acute UTI, which is why it becomes chronic in the first place. So the guidelines definitely need to be changed, but also symptoms are not taken very seriously either. So a patient could still be symptomatic after her course of antibiotics, and they would be dismissed because the cultures are coming back negative. Of course, that's something else we need to talk about, because it's a long discussion about the lack of testing at the moment. So yeah, for them to listen to the symptoms and take them seriously, rather than going off an outdated test that just is not sensitive enough to pick up the bacteria. So yeah, they're the main things really, isn't it? Is the guidelines and listening to that patient, what she's telling you, he's telling you, because obviously this does affect men as well, and not just going off the outdated testing. I'd probably say that's, like I said, the main thing really. That would stop this yo-yo effect of chronic UTIs.
Yeah. Do you want to explain the outdated
testing? Yeah. So the testing that they use, so a patient, so let's start from the beginning. So a patient would represent with UTI symptoms. That could be any of the following: burning when urinating, burning when not urinating, a heavy, full feeling in your bladder, retention, pelvic pain, urethral pain, kidney pain. There's lots and lots of symptoms. So a patient knows when they have a UTI. It's just something that we know, isn't it? We know the feeling. So the first thing we do is we go to the doctor. They will dip your urine straight away. Sometimes it comes up positive on the dipstick, sometimes it's negative. Again, it's not really a good enough test. But either way they do that, even if it shows negative, they still give the patient the 3 days of antibiotics. For men, it's longer. Men get a week to 2 weeks. We get 3 days. So they will hand out those 3 days of antibiotics. They will then send the urine off to the labs to be cultured, but they don't leave it long enough to grow bacteria. They should be leaving it around about 72 hours, and they're not leaving it nowhere near as long. And that's why a lot of people that ring back for the results, they come back negative, no action required, but that patient is still symptomatic. And they're told that there is no infection there. So, you know, it must be something else. And they're left then to suffer, thinking, oh, okay, I mustn't have an infection then, you know. And then they start to think, well, am I imagining this? You know, what is going on? Again, people, if they are getting repeated attacks, they don't flag up on the system. You know, what is going on? Why is this patient having 3 attacks in a month? That, you know, what's going on? They don't do anything about it. Again, they throw 3 days at them, and it's just making the situation worse. and the patient's mental health worse as well, because they're thinking, well, they're telling me I don't have this, but I do have this, you know, and it affects everything. They would then maybe refer to a urologist. So I'll go back to my story at the moment, what happened with me and what is happening constantly now to this day. So they will refer to a urologist, and that is absolutely okay to do that, because it's really important to rule out anything sinister. Of course, if there's any blood in the urine, it can mean, you know, something serious. Usually it is not, but it's really important to rule out that. So the urologist will go in with this camera cystoscopy, and he will have a look in the bladder to see what's going on. If there is nothing sinister showing there, then it's usually down to inflammation. So they'll say it's inflammation, there's nothing going on, I think you have interstitial cystitis or overactive bladder. They would then do a urodynamics procedure maybe, which is a horrible procedure, by the way. I've had this myself. It involves a catheter and it's extremely uncomfortable. You are led on a bed in stirrups and they use a catheter and they fill your bladder up with fluid and then kind of lift the bed up to see if, and you've got to tell them if it hurts and when you need to go. So they're constantly filling the bladder. Again, these things, if you already have an active infection, these are going to make the patient so much worse. You know, it's encouraging further bacteria and, you know, worsening the symptoms. They would then maybe give an overactive bladder medication. I took solifenacin, Vesicare. It didn't really do anything, didn't change anything. I still kept getting these attacks. Then it got to the point where it was daily pain of some kind. Then again, another thing that the urologists do, which is barbaric in my eyes, they would then do a hydrodistension, which is a bladder stretch. It sounds terrible, doesn't it? And it is terrible. So you're fast asleep for this procedure, and they will fill your bladder up with fluid to the point where it's about to burst. Then they would leave it there to bleed, and then they would release the fluid. So that's called a hydrodistension, which is a bladder stretch. Again, if you imagine you have an infection sat there in the bladder and you've just had this procedure, which I had, can you imagine what that's doing? You know, it's making the infection more embedded into the bladder wall. It's going deeper. Personally, that procedure for me ruined my life completely. I had sepsis from then on, and I was in 10 out of 10 agonizing pain. So I was given a wrong diagnosis of interstitial cystitis, and I was given wrong diagnosis of overactive bladder, and I had that awful procedure. I was given Elmiron, which is usually given if you are diagnosed with interstitial cystitis, and it's an anticoagulant and it's meant to regenerate the bladder lining. But again, side effects to that, you can lose your eyesight, you can lose your hair, gastric problems, the list is endless. But the patient feels they have no choice. You know, this could work for me, this could help me. So they'll listen to the doctor and they'll try it. So yeah, some of the awful things that I went through, again, all along, it was an infection. So if that testing was correct, if that doctor was listening to that patient's symptoms, then this would not be happening now. People would not have to go through these routes and be made to suffer for many, many years. I mean, by the time a patient finds the support group, for instance, they're already many years down the line of reoccurring attacks or IC diagnosis. So it's a very, very serious problem, and it's happening every single day. And people are having these awful procedures and being diagnosed wrongly with many other conditions, and it really is not that. So an acute UTI not treated correctly will lead to serious consequences. And the main one is sepsis, urosepsis. And sepsis is one of the biggest killers in the UK. So again, if you untreat an infection, it would lead to sepsis, which is deadly.
I think that's the thing that I find like so sort of frustrating and shocking about UTIs, is that actually in so many cases it has a quick fix or an easy solution, provided it's caught right at the beginning. And this isn't a, like, it can not be, it doesn't have to be a complex condition or a complex process. It just requires, as Joanne perfectly put it, like better technologies and better listening and better compassion, that, or sort of productive compassion, like someone actually doing something and it being attuned to your like specific circumstances. Because if you just had these sort of very straightforward and also very cost-effective interventions right at the beginning, then you're preventing decades of misery in people. And I think that's particularly demoralizing when you think about, it's not like a complex disorder that requires complex medications, if it's caught early. It can be corrected before it gets bad. And so it feels sort of, like a pointless, kind of like it just shouldn't have happened, I think, is so frustrating.
And it would save them a hell of a lot of money as well. If they treated it for just that little bit longer. They wouldn't see that patient constantly coming back through the door for another 3 days. Treat it properly the first time, and they could save them many, many years of misery.
Definitely.
And save the NHS a lot of money as well.
That's it. Like, you say this in the film as well, Joanne, like, why aren't people flagging it up, like, this person's been in here? I mean, I can actually just say exactly what you said because I've heard it so many times, but I'm not going to quote it exactly. But yeah, it's like, if patients come in 3 times that month and you're like, oh, it's a new infection, or you don't have anything wrong with you, see ya, that should not ever happen. And also, like you said as well, like that most people who get diagnosed with chronic UTI, it's been almost on average like a decade, and in your case 2 decades. It's crazy, and by that point the psychological impact is just like, it's almost like irreversible, because you've just been ignored for so long, and you've not known what's wrong with you for so long. Like, that's what's so horrible about it. My experience, and I know, and lots of people we've spoken to, is just, it's so, I don't know how to describe being sent away from the doctors and being literally told I've had doctors sort of not laugh in my face, but sort of be like, yeah, you don't have a UTI, like, sorry, what are you going to do? And it's like, and then I've broken down in the surgery, because it's like, well, so I've got all the symptoms, but I don't have it. And you believe them, you say, okay, well, I don't have that, then what's wrong with me? And then I've seen urologists, and they say, yeah, like, I had a cystoscopy 2 years ago, and they, just before I was diagnosed with chronic UTI, and they just said, yeah, everything looks fine, bladder's fine. And then it's like, okay, well, I guess that's good, nothing's wrong with me, but also I'm in pain every day, so something is wrong with me. But that's the end of the road. There's nowhere else to go after that. And so
no. And then you start to think, it's something very serious. It's not a UTI, so it must be bladder cancer. I hate to say that word, but I thought that. I thought, something really bad's going on here. I don't have a UTI, so what is this?
I think that thing though as well, which is, again, going back to the kind of, like, I think you summed it up really well, Joanne. It's like those 2 things, right? There's the like technical stuff that's sort of specific to UTIs, right? The testing diagnostic testing and guidance about course of antibiotics. Those are two very clear, and in some ways like relatively straightforward things that need to be resolved. They're like technological things. And then there's the big kind of cultural problem, which is something that UTI shares with loads of other conditions that predominantly affect women. I'm thinking when you're talking about, it's taken, it took me 2 decades, 10 years, it took me 7 years to get diagnosed with something, something like endometriosis has a very similar chronology, right? It's something that takes a really long time to be diagnosed. It's something that kind of is very difficult to pin, or is it under the current healthcare system very difficult to pin down. It overwhelmingly affects women or people with uteruses, and that kind of chronology is a product of doctors not listening to their female patients. And also, I think, as you said as well, Joanne, like not taking the evidence of symptoms seriously, that they only value one kind of evidence, which is the lab results, right? Like that's the only evidence that they will countenance. Whereas why is, women talking about them being in pain not taken as evidence of a serious illness that needs to be taken very seriously? And that again cuts across so many different things. There are lots of conditions that have a very similar kind of dichotomy, that the medical profession is like trained and set up to think about only this one type of evidence, and they're not interested in this other type of evidence. And I hope that I think one of the reasons why it is the right call not to interview doctors and stuff in our doc is because we want to show that women's experiences is evidence as well, and it's evidence that can be taken as seriously as biological markers or test results in a lab. In many ways they're way more important.
Because it shows that they're wrong and they're not working. You're like, well, no, but all these people have symptoms, and there's you're telling them that they don't have anything wrong with them, and you go, okay, what's wrong with the test?
Exactly.
And then you've got the whole elderly sector as well, Agnes, which we've spoke about before in the article. The elderly sector, especially the poor dementia patients that can't express the pain. There are so many care homes out there, millions of care homes with elderly patients, and again, because there is not enough information out there about chronic UTIs and where things are going wrong, they're left to really suffer awful effects, being sepsis and death, because it's not being rectified early enough. And like a dementia patient, for instance, the way that they would express pain is they're irritable. So they would, be moving around a lot. They can't keep still. They may shout, and then they'd kind of blame it on the dementia. She's having a bad day, or he's having a bad day today. When really, in fact, no, that patient's in deep pain. And your test is saying it, it's negative for infection, because they do that. They do that a lot in care homes. They do test the urine. The doctor will come out and they'll send it off. But again, we've got the same issue. And that generally, for a lot of people, ends in death, because an elderly patient that's already, their immune system is already, much lower than ours, they can't fight it. And the urosepsis deaths, I dread to think how many there are, especially in the elderly sector. It's very worrying.
I think that's also like absolutely also speaks to a broader point, which again is something we tried to get across in the documentary, is that this is obviously like a women's problem, but it's also a problem that intersects with lots of other categories, right? Like the elderly, like if you're a woman of color, like, and if you're a woman who can't afford private care, that exacerbates all of the different problems that we've already been talking about, right? Like that, so many people have to go and seek private care in Britain and elsewhere in the world, because the NHS isn't providing them with the things that they need. But obviously that sort of care is only accessible to a very small portion of the population, or people have to put themselves into very sort of precarious situations in order to be able to afford it. And so this is, and I often talk about, it's one thing to kind of advocate for yourself at a GP practice if you are, you know, old enough, resourced enough, you've got the time, you've got the energy. But there are so many people who don't have any of those kind of extra like things that you need, and it's exhausting having to not just be unwell, but then also having to kind of like be your own healthcare professional, or like advocate for yourself in a way that actually gets results.
Yeah.
I think that's something that Reem mentioned in the documentary, right? Can you hear me? Yeah, how she knows exactly what she needs. And she has to almost convince the GP that that's what she needs. Yeah.
Yeah,
absolutely.
I have a question for you, Joanne, about the support group that you set up. Because for me personally, so I suffered with UTIs for many years now, but I never was signposted to a support group such as the one that you created. Is it something that people just stumble upon by looking up for it, like looking for a support group, or do you also do some type of reaching out? And if so, how do you do that?
So it's a bit of everything really. It's at 10,000 now, members. It's linked in a lot of other groups, lots of interstitial cystitis groups, for instance. I do advocating on Instagram, but I've been doing this for many, many years. And the reason why I started it is because there was no group, you know, active on Facebook to support those that don't know about this condition. So there's lots of like UTI groups out there with the incorrect information in them. Thousands, in fact, of people can be in these groups, but it's the wrong information. Drink cranberry juice, you know, don't have sex, you know, just the whole wrong, lots of wrong information in them. So I knew there needed to be a group specifically for this, for chronic UTI. And that's why I started it. And it's basically been linked everywhere. It even comes up at the top of Google. So people have to pay for that, don't they? But it just comes up at the top. And that's because its URL is linked everywhere. And again, when people are that desperate situation, they're that desperate, they're typing in Facebook for groups, you know, I need help, what's going on? And then it's just, yeah, it's linked everywhere. And then, like I said, I do the Instagram as well. It's linked in Professor James Maloney's book as well. He mentions the group in there, in his book, Cystitis Unmasked. I don't know if I'm allowed to maybe talk about that at all, but it's definitely well worth a read. It's amazing. It's jam-packed full of information. He actually treats this condition. He's spent his life's work researching chronic UTI, and he successfully treats patients at Hawley Street, which is where I go, and many others. So it's Cystitis Unmasked, and it's well worth a read. It's full of science and everything there is to know about chronic UTI and other conditions that fall alongside it, like interstitial cystitis, for instance. He talks about that, overactive bladder, many, many other things. So yeah, we're also in Professor's book, the group. I've done lots of interviews as well with different people. So I think, you know, the more it gets shared, the more people know about the group, really. So yeah, it's very popular, very popular group.
We actually crewed up through some of these groups unintentionally as well, because our producer, Gemma Duncan, I met her when I was just spreading the word about the documentary in general, and Gemma messaged me saying, I'm a producer, I've been wanting to make a film about this for ages, and I've got a chronic UTI. And I was like, oh, let's talk. And then she came on board, and then our stills photographer, Kinvara Hubbard, she also met her and through the group, and she, you know, edited the film, but an editor reached out as well, so like I think we could have had every single role covered. Like it, you know, affects everybody. So
it's so scary, isn't it, how many people suffer from UTIs? Like, you know, you could be at work just having a chat, and you could be anywhere and people would say, oh, I get those all the time, and you're like, all the time? How often?
Yeah.
Oh, I get them constantly, they're horrible. And it's like, oh, that's not okay, you know. And you're like, and then you spend like half an hour explaining everything, and then they're like, oh my goodness, you know. But again, in terms of the NHS, we have the Lutz Clinic. We are very lucky that we have the NHS Lutz Clinic at the Whittington in London. So again, with that, the NHS clearly see it's an issue because that clinic is thriving. But again, they make it very difficult to be referred because you've got to go through the urology route or the gynecology route to get a referral. You can't just get a referral from your GP. And where do you go first? You go to your GP. That's the first port of call, isn't it? And again, you could be under the GP care for years before you get referred to a urologist. So it needs to be, this needs to stop. And they need to really start treating this head on straight away. It will save them money. They already know that it's an issue, like I said, because they have the clinic already thriving. We need more of them. This is never going to stop. It's never going to go away until that first issue is resolved. Testing, the first one, and then, you know, the length of treatment that's given for a UTI. Again, animals, for instance, you know, they get 2 weeks, which fantastic, you know. We don't.
Yeah.
A skin infection, you'll get 6 months of limacycline or doxycycline for 6 months. We get 3 days for an infection in a very, very serious organ that we use every day, very fragile organ that we use every day. We get 3 days. But a skin infection, you'd get 6 months.
Yeah.
Of a tetracycline.
You don't even get the 3 days.
Yeah.
So again, the 3 days on and off, to me, they're causing the resistance themselves because that patient is constantly being fed drips of the same antibiotic. Because from lots of research, I found that people will say, oh, that didn't work for me anymore. So they put me on cephalexin instead, and that's the only one that works. You know, trimethoprim didn't work. It doesn't work anymore. So they talk about resistance and how serious it is, but to me, they're causing the resistance with the little doses of antibiotics with UTIs. I mean, look how common they are.
Mm-hmm.
It's crazy.
I see that Kate Jen has raised her hand.
Oh, hi.
Hi, sorry. I just wanted to say just 2 things. One, quickly, that just there was a question in the chat. Can people contribute to the discussion? I want to make sure it's clear. Definitely, yes, please contribute to the discussion, ask questions, just raise your hand or put it in the chat and we'll read it out. And then I had my own question, which was like, it seems like a no-brainer, right? Like, it seems like a no-brainer that, you know, this is not the way to do it. It really makes me wonder, like, what are the set of circumstances that have, you know, they're the larger themes, right? Like, this is, you know, women trying to narrate their experience, and that we know that has sort of a pattern. You know, sort of these other kind of doctor-patient interaction kinds of things. But in this particular case, how did it come to be that there's a test that is not effective and that the treatment is limited to 3 days? And, you know, it just seems really sort of fascinating, right? Because it defies logic in a way. And surely GPs themselves who see this over and over and over again must start to kind of themselves maybe realize that and feel that way, but maybe are restricted in what they can do based on like what the standard of care is or whatever. I just wondered if anyone could say a little bit more about that.
I have some pet theories about why some of those things, which, I don't know how true they are. But one thing I think is that UTIs really suffer from their association with like the everyday and like being mundane. So I think a lot of GPs do not think, like Carmen was saying, right, the very common response, as a dog, a better antibiotic dog than us, probably. But there are, GPs that say things like, oh, it's very common. And so therefore, by extension, it's not worthy of my attention. And so I think that is part of the problem, is that UTIs have been really dogged by this association with like, oh, it's just a mundane, ordinary, everyday illness that is part and parcel of being a woman, that it's almost not even an illness, right? It's just a kind of consequence of our supposedly flawed biology that we just have to live with. And, to a certain extent, popular culture as well as, or like sort of broader culture as well as doctors kind of underscore that by insisting on things like, oh, well, if you just drink more water, or you can resolve it by over-the-counter medicines, or take cranberry juice, this is something that you can kind of self-medicate your way out of. But I think it has a bit of a knock-on effect as well on how seriously GPs take it, because I think, generally speaking, and this is my observation about doctors more broadly, is that they're not that interested in everyday stuff. And so it's not an exciting, sexy disease that that like attracts a lot of interest or enthusiasm or research funds, or and part of that is about it being we know that illnesses that predominantly affect women don't get as much research funding, don't get the big randomized controlled trials, and with some notable exceptions, like breast cancer. But generally speaking, these sorts of more like everyday things like lupus, endometriosis, adenomyosis, these sorts of conditions, they don't get the kind of research funding. And that's partly, I think, because they're just not that interesting to GPs. They just don't think they're sexy. And then you also see that as a problem, further up the kind of like consultant trail, is that they also fall kind of confusingly between different specialties. So like, it's often dealt with in urology, or as Joanne says, you can kind of go via the gynecological or the urological route. And most urologists predominantly look at male waterworks, and gynecologists look at female systems. And so if you're a woman that has a waterworks issue, you kind of float in between in this kind of complicated place. And if you want to be an expert, the reason why there's so few experts on UTIs, particularly in women, is that you have to have expertise in both urinary tract infections and also like female biology. And there are just not that many people who fit into those two categories. So I think the original tests were designed in the 1950s by someone called Edward Cass, and he designed them for a very specific and very small population. And then that test was very quickly applied to just all women inappropriately, that he himself, Cass, identified as inappropriate. He said from the very beginning, this isn't a good use of the test. So, and there has been research into the limitations of these tests since the 1950s, but because they've never been matched by large randomized control trials or by big well-funded research projects, that evidence of what, or at least kind of critical material in the medical literature, has never translated into a big change in guidelines or policy or practice or medical education. So yeah, I think obviously it's a very interesting question, and I think I didn't answer it, but hopefully some of that is a bit of an answer, at least in terms of what I think the problem is, or part of the problem is.
Mm-hmm. Thank you. We have a question or a hand raised, I guess, from Amy.
Hi, yeah, thank you. Can you hear me all right? Can you hear me?
Yeah.
Hello, yeah, cool. So yeah, thank you. I really enjoyed the film. I'm not a very tech for me being part of this. I'm not a very technologically advanced person. I live up in the northwest as well, on the coast of Cumbria, and so I didn't know about Joanne's support group, but I'll make myself go and try and find out on Facebook where to find that. But yeah, just really so supportive watching them. So I've had UTIs for about 20 years, and I'm 38 now, so from when I was 18, and just that, you know, surprising actually how, yeah, I've had a lot of conversations on and off, Joanne, with a lot of people that have said, oh yeah, I've heard quite a lot of people say, oh yeah, I had one of those once, and I'm like, wow, that would have been okay. So, you know, I quite often sort of get a bit close to people and think, oh yeah, we've got something, and then actually no, I'm still a bit on my own. So to see all your faces, I don't know all your stories, and see your names, it's nice to see a bit of a community, because I've definitely, partly the way that I am in my life, but I've kind of been on my own with this. So it's been very supportive, to say. I'd imagine cathartic to make the film. I can gather from you guys it was. Just that first scene, I think it was the first scene, it might have been you, Joanne, I'm not sure. It was like there was a pair of jeans, some legs, and a hot water bottle between the legs, and I was like, wow, the tears for me. It was like, other people put hot water bottles there, wow. So yeah, so just kind of seeing that and not feeling like, oh, was that you? Was that your leg?
Yeah, that was my cameo.
Crotch cameo.
Nice. So yeah, it was really good. But some of the question I was going to ask, or the thing I was going to ask about, I heard about this, I think it was yourself, Agnes, on Radio 4, maybe with a GP.
Yeah,
I'm sure that's how I found out about this thing. And whatever the doctor was, she's down in London. I think she's done some work maybe with the professor you've talked about, Joanne. I'm not sure. I'm trying to get to the bottom of it. But when I've looked on, they're not taking referrals.
No, Dr. Anderson. Dr. Katarina Anderson.
Yes, that's the one. And she talks about like the tests, or on the website it talks about tests they're doing down there. I mean, London's a long way for me, but obviously she talks about tests they're doing there that are like superior tests. And so that made me think, right, okay, so the superior tests that are there that are known about, so I presume they're just expensive, and as Agnes has touched on, loads of stuff around the dearth of research. So that's where it's at, basically, that they're for the privileged few that can get on that list, that have got the money, that can, and for everyone else, and not to mention, as you say, Joanne, that people in nursing homes, people with learning disabilities, people, you know, not able to speak out and access stuff.
Yeah,
so yeah,
and children.
That's it. Yeah, kids. Yeah. Thank you.
Absolutely. I mean, yeah, that is the other thing that I think is very frustrating about it, is that these, yeah, as you say, the technology does exist. It's not like this is a kind of problem that doesn't yet have a solution. You know, these tests are used relatively routinely in the US as well, where obviously they're very different, like funding structure, but they haven't been adopted by the NHS. I mean, I will say there is some debate amongst NHS doctors about what, you know, some of the sort of the flaws that we're talking about, right? There are plenty of doctors who say these flaws don't exist, that the testing is adequate, that the current guidelines are appropriate. And I don't know, Amy, if you heard on the BBC radio at the end of me and Kat kind of chatting, there was a sort of statement from the Royal College of General Practitioners, which kind of made it quite clear that they are satisfied with the status quo, and they think that it's, you know, completely appropriate. And so, you know, I think it can be easy when you spend a bit of time in the UTI world that we're in, to think that everybody, you know, a bit like how Caitlin mentioned, right, that it feels self-evident that this is a problem that needs these solutions, and that it just is hard to understand why. But there is a lot of, you know, there are lots of very traditionally minded people in healthcare, a lot of people who are very reluctant to acknowledge the shortcomings of both their individual practice, but also like the healthcare system more broadly. And you know, there are also lots of debates among the kind of like UTI communities about, you know, whether chronic UTIs or, you know, interstitial cystitis is a more appropriate diagnosis in which cases. So there is maybe more debate than perhaps, you know, we're putting across. I'm just not very convinced by the other arguments. But, you know, I think that is one of the other things, is that sometimes I've, you know, doing any kind of media work about it, I've had quite a lot of pushback from GPs who say, this isn't, you know, this is a bunch, effectively saying this is a bunch of histrionic women who aren't getting what they want, and they don't understand the system. So there's a combination of that, of like people, you know, this is like Google, you know, Dr. Google, who think they know better than the general practitioner who's got, you know, XYZ years of medical training. But obviously there are lots of people, like Joanne I think is an excellent example of this, who has very quickly and by necessity have had to become an expert in this condition in a way that a lot of GPs who are generalists just don't have. They don't have the expertise that they need, really, many of them, because they're not the training, the whole sort of a systemic problem. But yeah, I think it's I've gone off on a massive ramble.
Well, it goes back to the guidelines, doesn't it? Because if they don't have that to begin with, then how are they going to be able to?
Yeah.
And it's the dipsticks as well. I mean, the only thing they do is dip the urine. We can buy those from Amazon.
Yeah.
And do them ourselves.
Yeah.
That's all they do. They just dip the urine. They don't really listen to your symptoms very much, to be honest. And then they send it to the lab, which we know is, again,
flawed
or wrong.
And that's why a film like this is so important, because if people find it and watch it, it'll help them to stop gaslighting themselves. And hopefully, like, the more we stop gaslighting ourselves, the more we can produce this body of evidence that it is something that needs to be taken really seriously.
Yeah.
Amazing work.
Yeah, Carmen, Cajun raised her hand, and then after Cajun, I would like to ask a question to Cajun. You go first.
There's also a question in the chat.
Yeah, I was just going to say, I wanted to draw your attention to the chat. Shall I read it out? Can I ask what your thoughts are on current pain medication for this condition? There seems to be very little effective meds out there. And when you have an acute flare, it's debilitating and you cannot function. An effective pain medication to support us during a flare is most certainly needed. Is anyone aware of anything in the pipeline for this, any developments?
I can answer that. So yeah, that's a big issue, is even when you're in treatment for chronic UTI, it's not an easy route. So you do still incur flares, which can be extremely painful, even in treatment. And there isn't a pain medication that can target just the bladder directly. So the only kind of thing that you're given is morphine, cocodamol, things like that, which just don't touch it. They just don't do anything apart from cause addiction and make you feel rather unwell, actually. There is something that they're hopefully working on at the moment, is to try and create a painkiller that can be inserted vaginally to target that area of the bladder to calm the inflammation and the pain. I know that it is in the pipeline. I don't know how long it will be, but I know they are looking into it. Another pain medication that some people do find really helpful is diclofenac suppositories. They can really help, but again, not everybody can use them. Some people are allergic to it or don't have nasty side effects. But in the pipeline, yes, there is hopefully a pain medication on the horizon, but sadly, I don't know how long that will be. But yeah, that's the main issue, really, isn't it? Even when you're in treatment, is the pain element. It's just, I mean, you'll know, Rita, you're in treatment, and when you get a nasty flare, the pain can literally stop you in your tracks and you cannot do anything. You can't even watch TV in peace, can you? Without the pain just taking over your mind. There needs to be something quickly, because it would help people to stick to treatment as well, wouldn't it?
Mm-hmm.
Yeah, definitely. That's always been the thing, is they're really, I think that's why it's also adds to the hopelessness that you feel when you get a flare up or an acute UTI. You just think, you know that you can't really do it, you're just gonna have to wait it out, and that's sort of, you don't know how long it's going to be. And no pain meds. I don't actually take anything for it because there's no point. They don't help at all. It's hot water bottle and
hot bath.
Hot water bottle and chug that. The Demonos, just wait for the Demonos.
Demonos can help some people.
Side effect.
AZO. can help some people.
Yeah.
That's really,
Oh.
in fact, I'll just quickly mention that if anybody is suffering, it's not a curative, but AZID or urinary pain relief can be really helpful, especially if you get burning symptoms. That's that kind of, it's like a numbing agent, so it really stops any burning that you may get. The D-Manos, I've used the Sweet Cures brand personally, but there's lots of other ones out there. That's helped me in the past as well. But again, they're not curatives here. These are just things that could maybe help you with a flare to kind of make it a little bit easier for you.
We talked about this when I interviewed you, Joanne, but you know, before you're diagnosed, you have, you know, kind of read everything on the internet about it and have tried all these different supplements, and you feel like I remember going on holiday with a friend and they said it looked like Holland and Barrett in my suitcase because I had like, you know, 8 different bottles, and they didn't help. You know, none of those did actually help, because you sort of get, basically what I'm trying to say is, you before you're diagnosed, you do get sucked into this world where you're trying to cure yourself, and there's all these, you know, articles you can find in forums online and all over, from people all over the world saying, oh, this changed my life, you've got to try this and this, and you just throw money at it because you think, oh, okay, and then you get this little bit of hope, and then it arrives and it doesn't work, and then it's just this cycle of like, yeah,
you're desperate, aren't you, Rita?
Yeah, exactly. But I think D-Manos was one where I was like, this is it, found it, and it didn't, you know, it helps take the edge off it for me, I found, but it, you know, it never got rid of it. You know, I had a chronic UTI, so
yeah.
I think we had a question from Grazia.
Yes, I was wondering whether this is a very British or English problem, because I'm Italian and I've been living in England for several years, and I once had cystitis, and I went to see my GP, and then I was taken by the nurse in a separate room after describing the symptoms to the GP, and I was shocked because the whole procedure was completely different from what we usually do in Italy when you have that kind of symptoms. So the nurse, it was about 10 or 11 in the morning, and she gave me a cup. I mean, like a cup, like you can have it in a cafe. And she told me to put a urine sample in this cup, which was not sterilized, so it could have been contaminated, but everything. And I think maybe the following day, or I can't remember when, they called me to say that there was no sign of infection and so on and so forth. But anyway, I was shocked because in Italy, the procedure is completely different. So you can go to your GP, you can go to directly to a lab, and the procedure you follow is that you buy a sterilized cup from a pharmacy, and then you have to take the first urine of the morning, and then you take it to the lab, and it takes about 48-72 hours to get the results.
Yeah.
So I was wondering if I think so. They basically the urine. This is the culture method. So I was wondering whether this test you're talking about is used only in the UK or in England, and in the rest of Europe and the world things are done differently, or it is the opposite.
Well, definitely one of the participants in the film, Sophie, she is French, but was a student in the UK. And when she got her first attack, she was in the UK. And then when she went back to France, it was resolved. So part of her story is that like the French healthcare system was just much better at dealing with it than the NHS was. I know it's definitely very similar to the UK and the US and in Canada, but I don't know so much about the details of the kind of processes in mainland Europe, and I'm sure, you know, that it wouldn't surprise me if it's different. I mean, one of the big things is that like antibiotic management is very different in different countries. Like I've been on holiday in like France and Spain and bought antibiotics over the counter when I've had UTIs, which is obviously a very different experience to the one in the UK, but it's also complicated. You know, like I'm not necessarily suggesting that that's a good policy, but it does mean that you can get a resolution really quickly, unless you're me and you're really can't tolerate nitrofurantoin, which is the one that everyone always gets in the first line, and then just vomit for 36 hours. But for everyone else, it's probably great. But yeah, I think that that's, you know, it wouldn't surprise me at all that there are going to be different protocols in different countries. And I mean, I think the quality of the testing is relatively standard, but it's just that these newer tests may have been brought in more comprehensively in other places, which particularly places that have like a mixed economy of healthcare, that are kind of combo insurance and state funded system, where there's a little bit more latitude to spend a bit more cash on things like, you know, tests.
Thank you.
Can I break in just on that point? Because that was one of the things that occurred to me, was that, you know, there is this kind of like, don't give antibiotics, you know, God forbid, like, or that you should just ride out an infection that you have because your body will take care of it eventually. That sort of mentality. I mean, do you think that does actually has that played a big role in this? I mean, is that one of the kind of, you know, when you were describing sort of, you know, how it came to be this way, is that one of the factors, do you think?
Well, it's definitely been part of my personal experience, is that I've had to really battle with GPs to prescribe me antibiotics in the first place. And although I think they have never said, like, to me that, oh, it's because of antimicrobial resistance, I've always assumed that that was the motivation behind that reluctance. I mean, it is obviously a huge problem, right? That like the overprescription of antibiotics, or the kind of like management of antibiotics. But I would agree with Joanne and say that, you know, the current way that antibiotics are managed with UTIs, at least in Britain, isn't exactly good antibiotic husbandry, because it doesn't, you know, like I've had, especially since they often prescribe antibiotics before they've actually tested to see which bacteria it is. So I've gone through 3 rounds of different antibiotics before they've got the test results, you know, before they're like, oh no, this one works, you know. So you go through 3 rounds, which is obviously not good for anyone. And, you know, there are lots of strains of cystitis and UTIs that are antimicrobial, like resistant to lots of the common forms of lots of the common antibiotics that are used. But and that is also one of the biggest pushbacks that I've had from GPs when I've talked about this in like the media, is that they say, well, I mean, effectively the implication, right, is that this isn't a big enough issue for us to be risking resistance over. And I would say it feels like what you're doing is like throwing lots of women under the bus for the sake of something that is really your responsibility to be handling correctly. Not to mention, there are lots of other examples, much more egregious examples of antibiotic misuse in like current society that don't attract quite the same level of negligence or you know, control. So, yeah.
If it's all right with you guys. Oh, Rita, you were pointing to something.
Oh no, I just saw Nikki had her hand up.
Oh yeah.
Yes.
I think I'm the only one from Canada. Well, first of all, I'm so happy I found this group. It's been very helpful with lots of information. The challenge that I'm facing here is that, first of all, my doctor doesn't know, my GP, I had to ask her, like, can you just admit after 3rd antibiotic if it's not working? I'm guessing you've never treated this case. That's when she admitted that no, she's never seen this kind of a case. And she had to refer me to urologist. That was a challenge experience. And also the Hyprix, when I mentioned, nobody's heard of it. She's not ready to prescribe me. And then the main challenge is that I don't know if there's like a policy with how much antibiotics that the doctors are allowed to prescribe. And when I have presented them the prof's treatment, the Live Free UTI, the link, and his book, the urologist got the message. He knows, like now he sees what I'm talking about.
Right.
But I think they're very hesitant. They're not ready to prescribe a long-term antibiotics. And luckily, I was able to get him stop me from taking the third one, which was augmentin. I think that's what they call it, the amoxiclav, because that totally destroyed me like last week. He stopped me because it wasn't helping me anything. And so there's this, and also what I'm noticing is that most urologists, when I Googled up in Canada, I think their expertises are treating men's health problems, especially in a private practice, because I had to see a private practice. And I think that's where you make the profit. And I felt the whole, like the inequality between the female health and the male health. Like there's that inequality even in Canada. It was discouraging. And I'm the type of person that doesn't take no for an answer. So now I'm in touch with them. I mean, it's my health. And I told the urologist, if you can't fix it, just tell me. This is a costly treatment and I'm ready to go somewhere else. And I'm ready to fly to UK because the lab that I have been doing the test, I show them the prof's test procedure. They don't do that type of a test. So I'm not into that severe case right now, but if things don't work out, I'm ready to fly I'm booking my flight to UK and then I'm going to show the result to my GP. This is what you're going to have to do. Otherwise I'm going to be dying. So it was very challenging. And so my stage right now is I got in touch with, we have what's called the best doctors that I have through my employer. And thankfully I have like insurance, so I'm able to cover some of the cost, but because this is costing a lot of money too, but they're gonna contact the US specialist. And luckily the nurse that I spoke to seems to know what chronic UTI is. So they're getting in touch with the specialist in US who has been experienced with the chronic UTI. They will come up with a plan, the treatment that they recommend. And I will show it to either one of them. And I'm going to tell them, this is your job. You're going to have to treat me so and so way. So that's my plan. But I just find it very frustrating that this is many countries like UK, Canada, US. It seems like majority of us are kind of like ignored.
Yeah.
I think you've hit on something that's like a kind of, but very interesting to me and a kind of an important point, which is that I think a lot of people who aren't in healthcare, don't work in healthcare, sort of assume that there is a version of like standardization across that, like all doctors and all nurses will have the same ideas about something because it's, science, right? It's the same the world over, it's the same the country over, and that they will all have the same idea about like what the right thing to do is, what the right treatment protocol is. And I think especially that's true in countries that have state-funded healthcare systems. You think, oh, it's going to be standard across the board, that everybody's going to be entitled to the same care and get access to the same thing. And that just simply isn't true. And that's partly down to luck, right? Like whether or not you happen to have a GP who is proactive or has read up a bit of recent research, or has some personal investment in a problem. Or it might be because of geography, like, if you're in London or another big city, it might be you have a lot more options at your doorstep, like literal doorstep. And also it's obviously also down to cost, but even taking cost out of it, there are all these other factors that actually make the provision for something, especially like this, but about so many things, really patchy. And so you have to either be an incredibly powerful advocate for yourself, which is, too much to ask, I think, and we should not have to do that. Or you have to be really lucky. And that is not how we should be running healthcare. especially in places where we are supposed to pride ourselves on, universal, comprehensive, free at the point of access healthcare. It should not be down to good fortune and being, strong-willed to get the care you need and deserve. That's just like, that is the kind of real fundamental issue, to my mind. This is, obviously those inequalities are also deeply gendered and classed and raced and all these other things, but I'm really sorry. It sounds like an awful experience. And I'm really, I really hope you get like a resolution without having to fly to the UK, because I just flew to the UK and it was a nightmare. So, but yeah, I'm really sorry. It sounds awful.
Yeah, I love traveling to UK or other countries, but this is not the reason that I want to travel. Like I would go there for, a tea house and some shopping, something more fun.
Yeah, absolutely.
Yeah. But, thank you.
Thanks.
Oh.
We've been talking for over an hour now, and I was thinking maybe we should go back to talking about the film a little bit. I had a question about the film specifically. How did you decide on the length of the film? Because there's so much to say about this issue. So I was just wondering.
I mean, I think initially we thought, 5 minutes or something. It was sort of the way 5 to 8 was like, really sort of not random. I think when you make a film as well, you sort of think about film festivals and people's attention spans, and those are sort of like 10 minutes is sort of probably the max, a good length of keep people engaged and get the message across. But we're sort of aiming for a bit shorter than that. And then I had about 6 hours worth of audio from the interviews, and I mean, over the last few months, it's gone from like a 45-minute audio like sort of almost podcast, and then I've cut it down and down. Like the video came, if you've seen the film, the audio and the video were recorded separately anyway, so I just worked with the audio for so long. I think it got down to about 12, and I was sending it to Agnes and Gemma, and then we were sort of like, I mean, I just don't want to get rid of any more. Like there's just, I mean, we could cut it, I mean, but there was so much good stuff to use, and we got rid of a lot. But it was just a process of like listening to it a million times and thinking, okay, no, somebody has sort of made this point in other words earlier on, and so just being very like trying to get the points out in as quickly and sort of concise way as possible. And I think when we got to 12 minutes, I was like, this is the shortest I think it can be. So
because I think also that like brought into another conversation that we had like periodically over the course of the making of the documentary, which is like who the audience was, or who we wanted the audience to be. Because obviously one of the like pleasures of doing something like this is, it's obviously very awful to hear about people's experiences, but like all these people come out the woodwork, and like people people you don't know, who want to talk to you about UTIs, who've had their own experiences of it. There's obviously like pre-existing like a massive community of people who are very knowledgeable and very invested, very personally invested in it. And so we could have made a film just for those people, right? Like that would be just about like a kind of cathartic, emotional, which would have been amazing. That would have been great. And that could have maybe been longer, because you've got an audience who are already invested in this, in the subject, right? So have a longer attention span for something like this. But then I think we wanted to make a film that was, served those people's needs, but also spoke to people who might not know anything about UTIs and who might not necessarily be, the kind of captive audience of people who already are interested. And so for those people, it needs to be shorter, right? Because it needs to, like, people have short attention spans. It needs to be engaging. It needs to be snappy. And if we want lots of people to watch it, then it needs to probably needs to be like more concise.
Because we could have gone like if we could still do this, like we were saying earlier, make a podcast or make a longer form film that doesn't, maybe just is an interview, something like this.
Can I ask, sorry.
No, I was just saying we'll definitely do something with the rest of the 6 hours.
Definitely,
I was just interested, like thinking about audience. What are your plans for trying? Is this the film that you will put in front of physicians, or will you make changes to it? What do you think about them as an audience? Because as it is now, you could see it going multiple ways, but one way certainly would be to say, well, this is all of these people who have this problem, but they don't understand the medicine, or something like that. They don't understand how the system works. And I'm wondering what do you, I think you do, right, plan to try to get in front of medical practitioners. Do you change it at all to do that, or does it go in its current form?
This is it really. This is the form, I think, and I think it sort of is in a good state to be handed to them, really.
I do think that, I agree. I think in its current form, but I do think if we are going to put it in front of, and we plan to, in front of places like the RCGP or other kind of medical bodies, it will need I think some contextualizing. So I think it will need, my vision for it, I suppose, is to have, a kind of roadshow kind of style event where you have you screen the film, but you also have like filmmaker, participants, other people giving it a great, contextualizing it and sort of, and I think making clear, because there's so much we couldn't get in the film, a lot of stuff that we wouldn't want to get in the film, like the evidence that we think that this, our kind of critique is based on. So I think that there does need to be a bit of like a kind of Q&A dynamic, a kind of, because it's partly you have to think about how can you, I would love it for just be able to show a GP and they'd be like, oh yeah, no, this is really bad. I got it. We're going to change what we do. But I don't think that's a realistic outcome. I think it needs to be couched and delivered in such a way as to be more consumable somehow.
It's of something similar to this, we've watched film and then talk about it afterwards in this way, because people, you can feel like just reading the comments and in this chat, people, if you haven't, before you find a group or meet someone who's had one or get diagnosed, and when that does happen, you just want to you chew that person's ear off. I think it's like suddenly you can I've got someone to talk to about this, and it's very it's exciting almost. So I think to bring those people in, doctors into and do a roadshow.
Definitely.
What about, and maybe medical students, right? That could be a good
great.
Well,
really. The only thing I would also say, add to that is, I've thought about, and again, the film is, I think, perfect as is, but I wonder in that kind of context whether it would be useful to have a healthcare professional, like a sympathetic healthcare professional on board, because in my experience of working with doctors is that they do like to listen to other doctors first and foremost, and I think that would probably be something we could consider about how to get, how to sort of package it in such a way that it isn't off-putting to people. Not that it should be, but if we want to win over people's hearts and minds, then you might have to do a bit of playing the game.
No little forward or something.
Just to say that Sarah has her hand raised. If you would like to speak, Sarah, go ahead.
Oh yeah, sorry. Hi guys.
Hi.
Hi. It's just been brilliant as this, and it's so amazing that you're putting so much effort into raising the profile of this. It's only in, I'd say, the last 6 months that I've actually stumbled across this, and it's just provided such a wealth of knowledge and helped me join some dots, which is fantastic. It sounds like you're doing a really good job and you're wanting to get it in front of a lot of medical bodies, which is obviously brilliant and the right way forward. I just wondered what your thoughts are on trying to get it out there in the public domain more, so that it is really taken seriously. I mean, if we look at sort of like mental health up until like recently, that's another thing that was sort of just brushed under the carpet, and it took, you know, it's taken a lot, hasn't it, from not just celebrity culture, but you know, all kinds. It's like multifaceted almost, and it's finally come together, and we've now got Britain's got talking, and you know, there's much better investment in medication for it. There's all these SSRIs and new drugs on the market, and much better access to you know, support systems. Whereas I think we're still almost like not grassroots, but at the starting blocks with this. I just wondered what your thoughts are on how we might get it into the public domain more.
Yeah, so after this film came about because of Healthy Skepticism Project. So the premieres within the festival, but we are and have been the whole time looking for a permanent home online where you can just share it, you know, to whoever you want and spread the word. And that is the next step. We're figuring that out, who will host it for us. I mean, we may just put it on Vimeo or YouTube, and then it will be there. But it would be nice to give it more of a platform and release it in a way that like with some context, like within an article or something, you know. But we've reached out to lots of people, so
that's kind of the next phase of the filmmaking process, is like we've got the product now, and now it's about like disseminating it and getting it in front of lots of people and like raising a kind of buzz about it. And we've tried to do some of that along the way, you know, getting kind of newspaper coverage, and which we'll continue to do. And also obviously social media is such a powerful example of that. But that's what our like next step is to think about that sort of outreach side of it and use it as a way to generate a new kind of conversation and raise awareness and things like that.
Perhaps there are some gynecologists, such as my gynecologist, for example, my newest one, who really, like, those few ones who really know about this problem, who might be willing to have a discussion in the media, like with a newspaper or something, like being like, oh, I'm a doctor, and there's this issue we need to talk about, given that doctors are taken so seriously. And then link to the film again.
Absolutely. I mean, this is also partly why I want to do things like this, because it's, you know, something like this will only get, you know, more awareness and coverage by like crowdsourcing other people's like connections and, you know, like ideas and the communities therein, because obviously we both live in North London. So, you know, our community is our community, and so it's partly also about like trying to resource the UTI community more broadly to kind of get this sort of stuff out there. Who, you know, they're already doing so much, you know, Joanne's doing so much already, so many people are already doing this, but hopefully this is another, like, you know, weapon in our arsenal, like thing in the toolkit to be able to like encapsulate the problem in a way that's very easy to understand and like and you know, compelling. Yeah.
Sarah has her hand raised again, or is that the old one? I'm not sure. Oh,
Gone.
Okay. I had one final question about the film. Just generally, is there anything unexpected that was revealed in the making of this film for either of you? Or for Joanne, yes.
Unexpected revealed.
I think I kind of touched on this a bit earlier, but I think for me it was like, and this is just down to my own ignorance or like my own like sort of the trajectory of my understanding of the sort of landscape, but I definitely didn't really appreciate how fraught kind of politically and personally a topic, and how, you know, how divisive it can be. And this is also something that's like comes out of doing like media work, is that, you know, this is obviously something that's incredibly close to a lot of people's hearts, and who people feel incredibly, you know, and have had awful experiences, and are so understandably incredibly sensitive about the kind of subject matter. And so it, you know, I don't think I really appreciated, and this is, you know, been a learning curve for me, you know, how careful you have to be when you're talking about stuff like this, and how combustible these sorts of conversations can be, which I think is partly a kind of testament to how under discussed the issue has been for so long, is that then when there is, you know, increased awareness or increased sort of like kind of flourishing conversation, you know, there's a lot of pressure to make that conversation the right conversation, and to hit every, you know, important note, and make sure you get all of the right information across. And so I think that's been, you know, not like an unexpected, you know, it wasn't necessarily surprising to me, but it was definitely something that I have, you know, learned through the process of like making the film and publicizing the film, and, you know, researching the topic as well.
Yeah, I would agree.
Yeah.
What did I want to add? I don't know. I feel like, yeah, just
the stakes are high, I suppose, that's the thing, is that like, and they should be, that's good. But yeah, it's
it's like trying to, I think, you know, I was very aware after a while that I was not really talking about interstitial cystitis, or just the bit that Joanne, when Joanne talks about it, that's, you know, the only part where it's really mentioned. And I'd be curious to speak to people, because that's, I mean, I shouldn't really even bring it up right now, because it's a bit contentious between, well, people who have chronic UTIs and, you know, who have been wrongly diagnosed with interstitial cystitis for so long. So, you know, there are like other parts of UTIs that we didn't go into, and I think I was very, you know, trying to cover all bases, but also but keep it short and sweet as well. And, you know, that's why we need a podcast, basically, to delve into those other parts of it.
Why we need to make just way more people listen to us go on for way longer.
I'm not sure that Carmen is still here.
Yeah, I don't know where she's gone, but
she looks like she may have disappeared.
Drove her off.
Yeah, no, I can see her, but maybe she's got again some connection issues.
Yeah, she was frozen for a long time.
Yeah,
I was trying to decide whether she was just sitting very still or was actually frozen. But it's just about time for us to end. So I guess, you know, maybe we leave it with the three of you. Any final thoughts you want us to walk away with?
I think it'd be good to hear what's next for Joanne, really, because Joanne's doing loads of campaigning and talking to lots of important people. So
yeah, so there's going to be, I think you guys are already aware of the article. There's more articles to come, and the group's getting bigger. It's getting bigger and bigger by the minute. Which is actually very upsetting, isn't it? It's heartbreaking, really, with how many people are coming on the group every single day. I mean, Sam is here, one of my admin members on the group. He co-runs the group with me. I've just realized he's actually here just now. So that's Sammy. He works incredibly well on the group with me. He's massively into the scientific side of it. So if there's any science questions, he's your man. He knows a lot. In fact, I think he knows Prof's book, like word for word. Like, he's pretty awesome. So yeah, there's lots to come. I mean, the documentary was one of them, one of the big things that I always spoke about. There's an interview that I'm doing with Dr. Louise Newson as well. I'm sure you've heard of her. I'll be being on her podcast in November. So that will get around a lot as well. But yeah, just lots more interviews. The charity obviously is underway. chronic UTI global support, which is huge. We are absolutely astounded by the support from the community already. So we are just going through ticking the boxes now to become a charity organisation. So there's just a few more little things that we need to do. But again, it's global. So it's this is a worldwide issue. This is, not just UK, this is everywhere, and it affects everybody, all gender, all age groups. This charity is very much needed, and we need better research. We want the guidelines changing. We want them changing to stop the next generation from suffering from this. And yeah, we want a cure, basically. We want a better treatment option. There's people out there that can't take antibiotics. They can't tolerate them. They're allergic to them, or they have terrible gut issues, or really other severe issues from them. What about these people that can't do that? There is nothing currently for them. So we need to really look at everything, better treatment options for overall everyone, in each category, changing those guidelines and the research. We need more people researching this. Painkillers. We need a painkiller for this. This illness, when it's at its worst, there's people that, sadly, I hate to say it, commit suicide. They take their own lives because the pain is relentless, and it can really rise to the point where you really don't want to be here anymore. So we need to stop that from happening. And the documentary is amazing. That's gonna hopefully be shared everywhere, and loads of people will learn from that. I think, like I said earlier, Rita, the bits that you've put into the documentary are really, really helpful, because you've made it so that people that are not fully aware of chronic UTI or UTIs will watch it and go, that's me. I kind of understand this, and look into it a bit more. So yeah, the charity is going to be global, and hopefully, fingers crossed, it's going to be a huge success, and we can finally start to make these really important, vital changes to save people's lives, basically. So yeah, that's the really big thing. I can't believe I didn't say that at first.
I think that was what Rita was leading you towards.
Yeah,
I know. It's something. And the charity that I've started.
Yeah, it's nearly here. It won't be long.
Yeah.
Great.
Yeah.
Thanks, Joanne. Thanks.
But yeah, there's other organisations as well. Chronic UTI Australia do amazing work. They're on Twitter as well. They're amazing. There's Live UTI Free. I think there's a few others. I can't think off the top of my head. So yeah, there's lots of organisations that, well, not lots. There's a few organisations out there that have a lot of information available. And then obviously there'll be ours, which will be global. Hopefully it will make the changes that is desperately needed. I don't know if Sammy wants to say a few words. Sammy, do you or not?
Put on the spot.
Yeah.
No, I'm not sure I have much to add. I think you pretty much covered it.
Yeah, you're happy with everything. Yeah.
All right, well, that's great. Thank you so much to everybody for coming, to our panelists for telling us about the film and talking about UTI more generally. I think it's been a really, really productive and important thing, in a really lovely way, actually, to end our film festival. So thank you all so much. And there have been some comments in the chat, so maybe you guys, take a quick look through, and I'll sort of leave the recording going, but now we'll officially end, I'll leave the Zoom going in case you want to look through, but we'll officially end the recording right now. Okay.
Okay.
Bye. Bye, everyone. Thanks for watching.